Okay, hello everybody. So Anne, Laren, and myself are going to talk about the nutrition program in Kenya. Let me introduce you. Kenya is a country itself. Kenya is a country in Eastern Africa, bordered by 5 countries: Somalia, Sudan, Ethiopia, Uganda, and Tanzania, and the Indian Ocean on the east. 88% of the total land area are the arid or semi-arid lands, so-called ASAL, and approximately 20% of the country has a land which is good and for farming. The weather conditions in Kenya are changing. Kenya experiences drought as well as floods and environmental destruction. The major challenges in Kenya and as a country still remains food security and malnutrition, which we are going to focus on. Malnourishment in Kenya is a widespread problem which affects mostly people living in arid areas, slums, refugee camps, people who are less educated and impoverished. It has its 2 main forms: acute and chronic undernutrition and micronutrient deficiencies, such as vitamin A deficiency, iron deficiency, anemia, zinc deficiency, iodine deficiency. Especially the first one, the vitamin A deficiency, is a problem which causes loads of harm in children. It can cause a preventable blindness or increases the risks of disease and death from severe infections. Another group which is likely to be harmed is pregnant women, and the vitamin A deficiency in this case can cause night blindness or might increase the risk of maternal mortality. The early childhood anemia or iron deficiency can harm the physical and cognitive development and can lead into the weaker immune system for children and sometimes can even end with death. To improve or to increase the awareness, we have different types of interventions, but we've decided to mention 3 of them. Supplementation, which is giving the vitamins and mineral compounds in the form of capsules, liquid drops, tablets, but its usage is limited to vulnerable groups in emergency situations. Then we have food fortification. This intervention is very popular in the US especially, and it's enhancing the amount of essential micronutrients in a food in order to increase the nutritional value of the food, as well as offer public health benefits. Mostly fortified food are staples, just like wheat, oil, salt, sugar, and maize. Another type of fortification is the home fortification, where the micronutrients are being added to the food or to the meal just before it's being consumed. These vitamins or minerals are often in the form of a powder, which is being sprinkled over a commonly eaten dish, like, for example, porridge, given to the children. Home fortification has been effective, and the results show that it reduced deficiencies in young children. We've decided to compare the 2 most commonly used types of intervention: home fortification and micronutrient powder sprinkles on one side, and supplementation and micronutrient biscuits on the other side. They both were invented in the 1990s. The powder sprinkles were developed in order to find something else than iron drops, which had been used before but had shown negative side effects and also tasted badly. Powder sprinkles were produced on a commercial basis by Heinz, And there are several studies in northern Canada, China, India, Pakistan, Ghana, Bolivia, Bangladesh, and Haiti, in which the results show that the sprinklers really have been successful in treating anemia with rates from 49 to 91%, which really is a lot. On the other hand, the beneficiaries have been confused and skeptical about using this powder because they don't really know what's in the powder, and even though this is a good invention, for the past 15 years the powder sprinkles have not been picked up very often. On the other side, we have the micronutrient biscuits, commercially available in South Africa, Vietnam, and India. As they are regarded as a snack, they're more likely to be given in addition to a meal and less likely to be refused or misused. They don't require preparation and they're easily distributed. Results have also shown reductions in anemia, micronutrient deficiencies, and morbidity. Empowerment has been shown in cognitive function, body weight, and height. And but this product also has its let's say disadvantages, which is one of them that its shelf life is not as long as the life of the powder sprinkles, and also the efficacy studies on this product are still limited. Overall objectives of our project are to improve the nutritional status of vulnerable groups, especially children and future mothers, as well as refugees in Kenya. This goal is also a goal of the Kenyan Ministry of Health, and BDC Utopia is a fictional European country playing a role in this project. Objective of the Last Mile Solution team, that means us, is to decrease malnutrition among children aged under 5 by distributing supplementary nutritional cookies in pilot projects in Kenya. And we've divided it into 2 parts: Kakuma refugee camp on one side and Mathare slum area in Nairobi, the other one. And now Laren is going to briefly tell you more about our stakeholders.
So, as Eva said, I will just briefly explain the major stakeholders. As you can see, the black circle in the top right-hand corner, that would be the Kenyan Ministry of Health. In order for our project to be successful, we need their funding and we need their support. The gray circle is referring to the fictitious BDC Utopia, because they have a bilateral agreement with Kenya in order to reach the objective of improving nutrition among vulnerable groups. Then you see next to them the blue circle and the green circle. These would be the community leaders in the 2 areas where we will be implementing our pilot project, in the refugee camp as well as the slums. And then towards the middle line, the neon green and blue, those would be the beneficiaries themselves, the refugees in our target group, and the people who are living in slums with children under 5 years old. They don't have as much power, but in order for our project to be successful, they are very important. So Kakuma refugee camp. Kakuma is located in Turkana in northwest Kenya. The refugee camp was originally established in 1992 to accommodate the Sudanese. However, it's grown rapidly since then, and it's now at the point of being almost over capacity with 100,000 people. There are refugees from Sudan, Somalia, Uganda, Burundi, Ethiopia, and the Democratic Republic of Congo. And this area is very arid, dry, with average temperatures of 40 degrees and hardships such as dust storms, droughts, floods, outbreaks of malaria and cholera. And the reason why we chose this camp for our pilot project is because there had been a failed micronutrient powder campaign in 2009 which was mainly due to a lack of social marketing. They had introduced a micronutrient powder. However, the packaging was not culturally sensitive. There were cartoon figures on it, which were offensive to some religious groups. Because it was a silver small packet, many people thought that it was a condom, and they didn't know what to do with it. Many of the packets were found scattered all over the refugee camp. And also a huge issue was trust, because many people in Africa think that there's deliberate attempts to reduce their fertility, as well as maybe give some kind of chemical which might be bad for them. Yes?
Was it distributed for free, or did they?
It was distributed for free by the World Food Program, but another problem was they did not have a target group. They just mass distributed these things, and they did not have any education or a program. They came up with one afterwards, but it was already too late at that point. So our objective would be to increase the uptake of distributing micronutrient cookies to 6 to 36-month-old children participating in the integrated maternal and child health nutrition program in the Kakuma refugee camp. We would take 225 children, and we would divide these into samples of 450. And our objective would be to see if they were effective in reducing the prevalence of anemia and vitamin A. And we will assess this by using blood tests, urine tests, as well as qualitative interviews with the mothers. We will use extensive social marketing, and it will be very important that we achieve high interagency participation from the very beginning. We will have comprehensive training and monitoring during the program to make sure everything is going okay, and if it's not going okay, then we will need to make some adjustments. But in addition to just targeting this group, we think that it's very important to raise awareness about nutrition, and so we want to engage the refugees themselves. There are already NGOs that are working in these camps, and we feel that we can work with them to improve this situation. We would use community leader involvement, and by that we're referring to the religious leaders and the important leaders who are from each of these countries. We would also use things like theater skits to convey the message and how you should use the product properly. And the International Rescue Committee already has a mother-to-mother support group in place, so we would be working with them to get our target group, and also to conduct our evaluations afterwards. We would be observing these mother-to-mother support group sessions. International Film Aid is working actively with refugees to allow them to discuss important issues for them. And we would work with them as they have already made a film in 2009 about targeting anemia. And the UNHCR, we would work with them to have the refugees themselves make posters about nutrition, as well as the cookies that we are using, because by drawing and coloring, then they are being engaged and they are thinking about nutrition. Now I will hand over the floor to Anne, who will talk about our project in the slums.
You've already heard about malnutrition, and our project in the slums is just an indication of what is referred to as hidden hunger. That means that people who eat everyday food, for example, in the slum, may not eat a balanced diet. And hidden hunger refers to this problem, whereby a child receives a normal portion of food every day, but doesn't get, for example, a diet with iron or vitamin A, and as a result, it becomes stunted or remains underweight. And this is what is actually referred to as hidden hunger. Unfortunately, hidden hunger affects very many children. And in larger populations, for example, in a slum area like the one we're going to look at, with about 170,000 people, if a child is stunted and all the other children in the area are stunted, then it's taken as the normality. So nobody will actually say, oh, my child is sick. And in these cases, families, instead of spending money on a balanced diet, on buying leafy green vegetables and fruit, will even spend money on something like a TV, because they did not actually see that they have a problem at home. And this is actually why we are going to have a pilot project in a slum area to educate the slum dwellers about nutrition and create nutrition awareness. So, like I said before, it's a pilot project like the one being done in Kakuma, but the only difference will be that in the slum area, the cookies will be made available commercially. That means they will be provided, but to be paid for at a very small price, a very little amount of money. We discussed about 10 Kenya shillings, is less than 1 US cent. So we will also target children aged 6 to 36 months old. Why? Because usually children in this age are the highest prone to mortality deaths. So we will use indicators such as the sale of cookies to determine how many cookies are being bought, because we are going to use the push strategy whereby we will recruit social workers, and the social workers will go door to door, knocking, asking which families have children in this age group. And when families have these children, they will speak to the mothers, tell them about the program, nutrition and nutrition awareness, ask them if they want to participate in our pilot project. If they do, then they will be registered, and to find out if any progress is made. And as an incentive too, they will be sent to the local healthcare. There's a healthcare facility in Mathare slum. The children will be weighed and blood tests will be done, all free of charge. The most important thing in this setting will be that the health workers, we will not just tell them about the vitamins. Or if you give your child this cookie, then your child will be healthy. They will look more at the attributes and say to them, if your child eats this cookie contains iron, this cookie contains vitamin A, which makes your child have nice, healthy hair, or thick, long hair, and will make your child have energy levels to run around, will make your child have very good skin. So they will not exactly try to sell the vitamins, but the attributes of the vitamins, or the product of using the vitamins. Testimonials will also be used. So any families who are registered and who take part and who are happy after the 3-month testing, whose children make progress, will also be asked to make testimonials. And these testimonials can be used also in the refugee camp and also in a wider project that would be undertaken to cover another slum area or another urban area. So as you see here, one of the lines that the social workers could probably use is, give your child a cookie a day and they'll become more clever, or they'll have a brighter smile because they'll be happier and not weak and tired. Another thing would be, we would also like to try not only to target the mothers, because the mothers could be the people who buy the cookies, but most of the time the money is given by the fathers. So we would also try to look at a wider range of people, to target a wider range of teachers, community elders, and people who would actually see this as part of bettering the entire slum area. As part of our pull strategy, because in the slum area, we are assuming that people have a little bit of money, although they may not spend all of it properly, but we are hoping that our pull strategy will actually encourage them to buy these cookies. So for every pull strategy and for every successful campaign, you may have heard from Mr. Mela that a logo is very important, a symbol. So instead of the high energy biscuit, we will be marketing the cookie. And as you can see, the cookie is going to be our logo, the smiley cookie. It's going to be on all our products, in all our brands. The cookies will be in different flavors, of course, to make them more attractive to the children. There'll be a chocolate flavored cookie, there'll be a vanilla flavored cookie, but all these cookies will all contain the vitamin A and iron that will be required by every child. You may ask yourself also, why just a cookie? It's just that we discussed it and realized many children don't eat an entire portion of food. And a cookie that has all the nutrients that are required would be an optimal way of ensuring that the children get their required amount. So our health workers or social workers would go around the slum area and also in the refugee camp in Kakuma, wearing the T-shirts, which have the logos. The delivery trucks that actually deliver the cookies would also bear this cookie symbol. And in every setting, in every instance where the social worker goes door to door, they will also, ask the mothers, how are the children doing? They'll record any instances if a child has developed an infection or if the rates of infections are actually diminishing. They will also take the opportunity of these weekly visits to also sell an extra packet of cookies to the parents. The last symbol there, which is the cookie on top of the money, will be used for sponsors. Of course, at the moment we are funded by the BDC Utopia, but in future it could be that if this campaign is successful, that we may have to go on, but would need money from other sources. And so any company that sponsors us or is willing to support us in any way would receive the cookie with a $, which they can hang on their door or in their building, which indicates that they are their supporters and they're in solidarity with us. These are some of the posters that will be put up in billboards throughout the slum area. One of them, our main slogan is "A cookie can make a difference." The other one is "A cookie a day can keep the doctor away." And this we hope to really encourage people that they can actually see that a cookie can really make a difference. As part of our full strategy, we'll also have a website, which will have all the information about the project. It will also have information how we are spending the money that we have. So we are very much for transparency. And there will also be a promotional film. You've already heard from Larin that we'll be making a film. And this film will also be used to, will be screened in settings within the slum area. The team at Last Mile Solutions will be quite large because our project is running over 3 years. We'll have mostly local employees to try and uplift standards of living generally. 20 social workers who will be working within the slum area, and some of them, of course, will work in Kakuma. We'll have some health workers, researchers. We'll also have a team that will be responsible for the PR section of the project. Our headquarters will be situated in Nairobi, so of course we'll have to put up an office, and we'll need office equipment, and yeah. And we will also take the opportunity, since we are based in Nairobi, to also collaborate with all the other NGOs who are based in Nairobi. As I said, the budget is quite extensive. We had received $860,000, and our budget from what that we've estimated at the moment is $646,000, which will be spent on office space, which will be used for training workshops to train our social workers and teach them the communication skills and the communication message, which they have to spread to the audience that we are going to have. The web page will also cost putting it up and maintaining it. A very big chunk of the budget is about $49,000 will be going to promotion and advertising. So, and the rest is going to be taken up by office staff and office space. The buffer of what we have, what will be the balance, will be used as a buffer because there are very many unexpected costs. As you may have heard before, Kenya is not a very transparent country. Some corruption may occur whereby we are asked to, give 10% here and there. So this amount of money that we've not spent will actually be looking at such costs. Okay, and now Lauren will actually tell us about the evaluation and how we'll go about it.
Okay, so to measure our success, we will use the following indicators, some of which I've already mentioned. So we would like to decrease the prevalence of nutritional deficiencies, and we will measure this by cases of anemia and vitamin A deficiency using blood and urine tests. We would like to improve the quality of life of the child, and we will use quality of life questionnaires, which will be answered by the mother. We would like to improve the quality of the intervention, and therefore we will have qualitative interviews with the beneficiaries as well as testimonials. And we want to improve the intervention by using questionnaires and the observations of the health workers and the stakeholders involved. And we will also be using the measurement of sales from the product in the slums. Going back, Kakuma will be evaluated with the 4 different sample groups. We will do blood tests every 2 months, and then there will be another final evaluation when each sample is discharged from the study. And then we will compile all of our results at the end and make a report which we will use for advocacy purposes. And in order to evaluate in the slums, we would try to look at monthly sales and how many testimonials we are collecting. We may have some difficulty because we would be working with the Baraka Health Center, and they have a very good food nutrition program. However, this is just an option for the people, and we are referring them, but we are not sure if they will actually go. So in this case, we're not sure how to evaluate, but we will be working with the Baraka to look at their health indicators as much as possible. The time frame, we will begin preparing, or we have already begun preparing, and we will do that until December. Then next month, we will be doing recruitment. We will mainly be recruiting from local NGOs within the slums, as well as within the refugee camp. And then we will also be recruiting for our own team at Last Mile Solutions with the 20 social workers as well as our employees that we will need. Training and education will take place between December and January. This will be for the health workers who are distributing the product, because we want them to be able to educate the refugees and the people in the slums about proper usage, because that's the most important thing. The pilot projects will begin in February 2013, and they will last about 18 months. Then evaluation, as I said, will already take place during the project, and the final evaluation factors will be considered at the mid-March, about 6 months before our project ends. And social marketing will begin earlier on, before we get the pilot projects running, because we need to recruit for the pilot projects, so we need to already approach the community leaders and make contact with them and get our message out there. So the main conclusions and lessons learned, which can be applied both to the slums as well as refugee camps. Participation of the beneficiary and interagency collaboration from the onset are crucial. Detailed and careful research, as well as pre-testing, is necessary, and nutritional interventions must be promoted by trusted community leaders, the health staff, and social workers. Extensive training of the distributors is required to educate the beneficiary in a clear and effective manner. Logos, packaging, ingredients, and flavors should be culturally appropriate. And after implementation, usage needs to be diligently monitored, and you cannot mistake initial uptake for how it's going to carry out throughout the whole project. And even if the beneficiary is vulnerable and impoverished, and even if they can't pay for the cookie, you can have the assumption that the acceptability of the product is going to be high, because social marketing is what's necessary in order to make these projects work. Thank you very much for your attention.